Thank you to everybody. I'm pleased and honored to be invited to this very interesting forum. My main aim is to make clear how important is the monitoring and the evaluation of the services, especially in this phase where when we are facing some changes in our services. So first of all, I want to show you which are the dimensions that we need to monitor and to evaluate. We can make this monitoring exercise going through different settings. It's possible to monitor the inpatient care, of course, the outpatient, the daycare, the residential facilities, and also the social services. And most important is the level of the monitoring. We can take our indicators at input level, and one important indicators at input level are costs, are the money we put in the system, we introduce in the system, but also the input is the indicators that are important for input are equity, accessibility, and also the accountability. Another important level of the monitoring is the process. Many indicators are useful and give important information about the process, the capability, the continuity, the appropriateness of the services, the capacity to respond fast and appropriately to the needs of the population, and the safety also of the services. I will show you later some examples of these indicators just to make clear. And then another level of the monitoring exercise is the outcome. Before me, Angelo Barbato already showed you studies that used the outcome as an indicator, so efficacy, effectiveness are usually these studies. We developed this interest about monitoring and about the epidemiology of mental health services in Italy after the psychiatric reform. You know very well, I think, the Italian reform that was approved in 1978 and changed the system of mental health care very radically. Was the only reform in Europe that make this radical change, so to close definitively closing of mental health hospital, and the only possibility to admit people was in acute psychiatric wards in general hospitals. This reform started by the input of Franco Basaglia in Trieste, and at the end of the reform our mental health department are very well integrated system. At the center of the system we have the mental health centers, and the other parts are satellites of this system. So the focus was moved from the hospital to the community. The acute psychiatric wards is just one part of the system, but the center, the core of the system is the mental health center. You can see that there are different services that are provided, including consultation liaison, sheltered accommodation, and so on. And the system is provided by multidisciplinary teams, probably as well as you have here in Greece, composed by different professional types of professionals. So, to monitor this complex system, in 1978 in Verona we developed a psychiatric case register that worked since 1978 without interruption. So the system monitored all the changes in the after the Italian reform. And I show you some, of course, to maintain an information system and to provide good data to the interpretation, a good interpretation of the data of an information system like this, you need multi-professional teams with statisticians, geographer, data manager, and so on. And this is the team that I coordinate in Verona. Also, our team is integrated within a research center funded by Michele Tanzella that is very complex with different units on pharmacoepidemiology, brain imaging. The integration between these different units is very important for the interpretation of the data. But I want to show you how we work on this database. For example, you can see here what changed after the reform in Italy. The number of days in hospital was reduced dramatically, and instead, on the other hand, the number of daycare contacts, sheltered accommodation, and outpatient and community contact increased rapidly. In Italy, after the reform, we have the lowest number of beds in hospital in Europe. You can see Italy has about 2 beds for 10,000 people, and is the lowest number of beds compared with other European, Eastern and Western countries. Of course, this process is common in all Europe. The reduction of beds started in 1978, and each European countries reduced the number of beds. I think I searched before for Greece. I think Greece is in the middle of this range. It's about in 2005 was about 90 beds per 100,000 population. So this is one possibility to use the data of a mental health information system. Another way is to use this data to show some problems in the system of care. For example, you mentioned, the lawyer this morning mentioned about the rights to life. So you can use a mental health information system and data to monitor this right to life. Why the psychiatric patient die more than the general population? As the psychiatric illnesses are not mortal illness. And the mortality of psychiatric patient is about twice the mortality of the general population. So this is an important point. Of course, part of this mortality is due to the chronic exposition to psycho drugs. This is something that is difficult to change. But another part is due to stigma, is due to behavior of the patient. For example, if you look at the mortality, the difference between the mortality of psychiatric patients and general population linked to chronic liver disease is 25 times the mortality of the general population. If you look at the neoplasm of trachea, bronchus, and lung, you see, is about 3.5 times the general population. This means that alcohol and smoking kills more psychiatric patients than in the general population. So we have to do something to avoid the stigma and in this problem for our patients.